with you briefly, but the empathy and compassion that you carry in taking care of this disease burden that is so impactful in our lives, in our society, is to be reckoned with and to be highly appreciated. So thank you. The little bit that I want to add to this conversation is, I came at this from a very different point of view first of all, as a family member, because my mother-in-law was diagnosed with breast cancer as I was getting married into the family, and really as an engineer who did not know the first thing about cancer, or let alone breast cancer. And I was shocked to learn and understand the disparities that existed in the developing world, where I also learned not only did I learn about cancer, but I also learned that it's a disease of prosperity. As a society progresses, as a people elevate themselves out of poverty and towards progress, cancer increases. And there is a wide variety of reasons why that happens, but it is the fact. And particularly in case of breast cancer, I understood that it's a highly treatable breast type of cancer, where the survival rate could be upwards of 95% should the person get diagnosed early and brought into treatment on time. And this is the missing piece I found where we could really contribute some energy and effort to make a difference. And the challenge really, it was one of access, one of affordance, access, and the tools and technologies that have been developed, particularly in case of breast cancer, namely mammography. And mammography has been getting better and better over the years in the United States, the type of tool that it is. But inherently, this technology is inaccessible or unavailable largely in the developing world. I also learned that this technology needs experts. You need to be an expert radiologist to be able to interpret whether there is a breast cancer lump, problematic tumor present in the breast. And again, this resource is largely unavailable in developing countries all throughout Latin America, Southeast Asia, India, China. These countries do not have the expertise, radiological expertise, to operate this technology. And so myself, along with my partners, we rolled up our sleeves and said, what can we do from an engineering standpoint so that we can provide access when mammography is not able to get there in time? And we felt this tsunami coming from LMIC standpoint, and it's been true in the last 16 years that I've been doing this work. Numbers have doubled and tripled in the countries where we've been serving over these years.
And what are those countries, Mihir?
I'm sorry?
What countries are you referring to? So that our viewers don't know what LMIC means. Lower middle income countries, yeah.
This is India, which is 1.4 billion people. This is Latin America, which is another close to 1 billion people. This is Southeast Asia and Middle East and North Africa. And we've helped develop technologies that emulate the experience of clinical breast exam by standardizing it through technology, by making it such that community health workers can offer high quality breast exams virtually anywhere. We had to develop technology that that shouldn't depend on continuous power from the wall, regular electricity. We had to develop technology that could work without the internet, technology that was easy to use and did not require complicated expertise or high-end radiological expertise to interpret what's going on while performing the exam. And so while developing this technology, we really, over the last 5 years, we really understood that the disparities that exist in LMIC are also representative here in the United States.